Welcome back. We're going to talk about platelet disorder in this section. In last section, we'll talk about sickle cell anemia, multiple myeloma. We will focus on heparin induced thrombocytopenia. We'll talk about how to do diagnosis and how we do management. We'll start with question. Question number 1. Patient is on subcutaneous heparin for DVT prophylaxis for last 2 days. She had a joint replacement 3 days ago. Her platelet count dropped from 200,000 to 120,000 in 2 days and she's asymptomatic. What would you do for this patient? Option A, start her on oral anticoagulant therapy. Option B, calculate her 4T score. Option C, order heparin platelet factor 4 ELISA test. Option D, order serotonin release assay. So here the right answer is option B. We calculate 4T score. So hit can happen even if someone had exposure in past 90 days. Although our patient had exposure in last 2 days, I just want to make one point, it can happen up to 90 days or even more than that. Now, option A, C, and D are incorrect. We will discuss that in next couple of minutes. So let's talk about 4T score. So 4T score has 4 components. Number 1, thrombocytopenia. First T stands for thrombocytopenia. 80 to 90% patient who have hit, they have thrombocytopenia. The second T is timing. Timing is very important. We'll talk about that. Number 3 is thrombosis. 30 to 50% patient who have hit, they can have blood clot. And last T is other causes. So 4T score we calculate if you are suspecting hit. So if you calculate 4T score, patient can be categorized into 3 categories. First category is 0 to 3 point. So patient who have 0 to 3 point, they have low probability of having hit. Patient who have 4 to 5, they have intermediate probability of having hit. Patient who have 6 to 8 score, they have high probability of having hit. Okay, so let's calculate our patient 4T score. So her platelet count dropped from 200,000 to 120,000. So she has a 40% drop in platelet count. She gets 1 point. Timing. So if patient have drop in platelet count within 4 days, their likelihood of having hit is very low. So our patient got heparin 2 days ago and platelet count drop, so she gets 0 point for timing. Thrombosis, I told you she has no evidence of blood clot on examination, so she gets 0 point. Now other causes, she had a hip surgery or joint replacement. She could have other causes of having low platelet count. We will give 1 point, so she gets 2 point. So 0 to 3 patient have a low probability of hit, so we are not going to do any testing for her. Okay, so let's talk about flow chart. So if you are suspecting hit, you calculate T score. If T score is 0 to 3, patient usually have low probability of having hit. Hit is more unlikely. You can justify continuing heparin. So let's talk about what happened in our patient. Why did her platelet count drop? So there are 2 kinds of hit, hit 1 and hit 2. Hit 1 is a benign disorder, hit 2 is a malignant disorder. So hit 1 onset happened within 1 to 4 days. Hit 2 typically happen after 5 days. In hit 1, platelet count typically run in the range of 100,000 to 150,000. Hit 2, patient will have more than 50% drop in platelet count. So if patient come with a platelet count of 500,000, they can have platelet count less than 250,000. So that indicate hit. So more than 50% drop. In hit 1, it does not drop that much. Incident, hit 1 is more common. 10% patient can have hit 1. Hit 2 is less common. 1 to 3% patient can have hit 2. Etiology for hit 1, it is a non-immune disorder, and on hit 2, immune mediated. We'll talk about that in next slide. Now outcome, hit 1 is a benign disorder. Patient usually recover. They do not get blood clot. They do not get arterial or venous thrombosis. HIT2 is a malignant disorder. 30 to 50% patient can have DVT of both arterial or venous. So let's do question number 2. Patient is on subcutaneous heparin for DVT prophylaxis after CABG, coronary artery bypass surgery. Platelet count dropped from 200,000 to 80,000 in 6 days. So this patient has more than 50% drop in platelet count, and the timing is more than 5 days. So this is significant. You calculate patient T-score, it is 5, which give this patient intermediate probability of having HIT. So you stop the heparin. On examination, patient has no evidence of DVT. What would you do for this patient? Option A, start patient on warfarin. Option B, start patient on enoxaparin, which trade name is Lovenox. Option C, order heparin platelet factor 4 ELISA test. Option D, order serotonin release assay. So here the right option is option C. So we will talk about warfarin and enoxaparin is not indicated. Enoxaparin can also cause HIT. So we do not give enoxaparin if you are suspecting HIT. Warfarin we do not give until unless you have ruled out HIT, or if patient have confirmed HIT, patient should have platelet count more than 150,000 and you have to bridge it with direct thrombin inhibitor. We'll talk about that. Why we did not order serotonin release assay, we're going to discuss in next couple of minutes. So let's discuss the concept of heparin platelet factor 4 ELISA test. So platelet have alpha granule which secrete platelet factor 4 which help in aggregation. In the presence of heparin, some patient can develop antibody in their circulation which are platelet factor 4 antibodies. So this Y is an antibody. So these antibodies can combine with platelet factor in the presence of heparin, which can cause immunogenicity, which can lead to thrombocytopenia in 80 to 90% patient and thrombosis in 30 to 50% patient. So it's very important. If patient have a intermediate probability based on T-score, you should order platelet factor 4 antibody. So this is the pathogenesis behind ordering platelet factor 4 antibody. So let's calculate our patient T-score. Why did we give patient 5 T-score? So patient had a more than 50% drop in platelet count. So patient get 2 points. Timing more than 5 days, which is significant for having HIT2. So patient get 2 points, total 4 points. Patient has no evidence of blood clot on examination. Patient gets 0 points. Patient had recently CABG. There are a lot of causes of having thrombocytopenia. So we give patient 1 point. So patient who have 4 to 5 points, they have intermediate probability of having HIT2. So let's talk about patient who have intermediate to high probability of having HIT, who have a score more than 3. You do 3 things, okay? If patient T-score is 3, you do 3 things. First thing, you want to stop heparin or warfarin, okay? These patients should not get heparin from TPN. If they have a central line, they should not get heparin product at all. Second thing you're going to do is you're going to order platelet factor 4 antibody. The third thing you have to do is you have to start them on direct thrombin inhibitor. So let's talk about direct thrombin inhibitor. There are 3 direct thrombin inhibitor which we can use for these patients. Number 1 is if patient have a CKD, we can give them ergatroban. If they have liver disease, you can give them luperidine. And if they have both CKD and liver disease, you can give them bivalirudin, which is Angiomax. So what about newer direct oral anticoagulant, dabigatran, apixaban, or rivaroxaban, which is Xarelto or Eliquis? So can we use these medication? Now these medication are not FDA approved for HIT. However, you can use it off label if direct thrombin inhibitor are not available, if patient do not have line, and if patient have contraindication to direct thrombin inhibitor, you can use it off label, but it is not FDA approved. So let's do question number 3. Patient platelet count is dropped from 200,000 to 80,000 in 6 days. T-score 5. You DC the heparin You order platelet factor 4 ELISA test, which is positive with optical density of 0.80. You started patient on IV ergatroban because patient GFR was 20. No evidence of DVT on exam. So this patient have intermediate probability of having HIT. So you did 3 steps. You stopped the heparin, you did platelet factor 4, and you started patient on direct thrombin inhibitor, which is IV ergatroban. Patient had CKD. So what is the next step? Option A, start patient on warfarin now. Patient platelet count is 80,000. Option B, start patient on rivaroxaban, which is Xarelto, trade name is Xarelto. Option C, order serotonin release assay. Option D, order 4 extremity venous Doppler to rule out DVT. So here the right answer is option C. Let's talk about that. So option A is incorrect. We give warfarin if patient is confirmed with HIT and if their platelet count is more than 150,000. In some case, we can even justify giving more than 100,000. So this option is incorrect for the time being because patient platelet count is low. Second option is also incorrect. We don't give Xarelto if patient have CKD, and we don't give oral anticoagulant until unless patient platelet count improved more than 150,000. So just same concept as warfarin. So option B was incorrect. What about option D? Why are we doing 4 extremity venous Doppler to rule out DVT? So we do patient who have a confirmed diagnosis of HIT. 30 to 50% patient can have DVT. Even if they have no physical exam, they can have silent DVT. These patients can also have cerebral venous thrombosis. They can have they can have arterial thrombosis. So your likelihood, your threshold for ordering venous Doppler or imaging should be very low. If patients are symptomatic, if they are having headache, if they are having abdominal angina, you should do appropriate imaging right away. If they are asymptomatic and you have confirmed they have HIT, you should just order 4 extremity venous Doppler to rule out DVT. So let's talk about why did we order option C? Why did we order serotonin release assay? So let's discuss the concept behind that. So what we do, we take patient serum, we incubate with donor platelet, which contain a radioactive 14 carbon, which is attached to serotonin and heparin. So the first we take donor platelet, which are normal platelet. It has serotonin in it, and we radio label it. In the presence of heparin and patient serum, we combine them. So what's going to happen? Antibody from patient serum will activate donor platelet. That will release radio labeled serotonin from the platelet. So this test is very sensitive, very specific. If patient serum has antibody, then it will release radio labeled serotonin from donor platelet. So if this test will basically confirm the diagnosis. Okay. Platelet factor 4 antibody test is very sensitive, but it's not very specific. This test is very specific. So let's talk about why did we order serotonin release assay. So if you order platelet factor 4 ELISA, depending on your institution, you might get result in the term of optical density. If they give you optical density, if it is less than 0.60, this essentially rule out HIT. If they give you optical density between 0.60 to 1.99, you should order serotonin release assay. Our patient optical density was 0.800, so that's why we ordered serotonin release assay. If they report optical density more than 2.00, this essentially confirm HIT. Most of the time you don't even have to order serotonin release assay. So it's going to depend on your institution how they report it. In some institution they will report platelet factor positive, ELISA is positive or negative. But if they are giving you optical density, you can use this flowchart to justify whether you have to order serotonin release assay or not. So let's do question number 4. A patient was diagnosed with HIT. Patient has a confirmed HIT. T-score is 6. Patient ELISA optical density is 2.0, which is pretty high. Patient has a positive serotonin release assay. 4 extremity venous Doppler normal. Patient is on IV ergotamine. Platelet count has improved from 80,000 to 160,000. What would you do for this patient? Option A, give patient warfarin for 4 to 6 weeks. Option B, document heparin allergy in the chart. Option C, do both A and B. Option D, no further treatment. So here the right answer is option C. Although we have ruled out DVT in this patient, these patients they have very high risk of having DVT in next 4 to 6 weeks. So you can justify giving short course of warfarin. And you have to document heparin allergy in the chart, because patient can get heparin from TPN, they can get heparin from PICC line, they can get heparin with dialysis catheter. So you have to document heparin allergy in the chart. So in rare circumstances, we can justify giving heparin if patient is going for cardiopulmonary bypass, but apart from that, we should not be giving heparin to these patients. So if patient has no DVT with HIT confirm, you can justify giving warfarin for 4 to 6 weeks. This is not a strong recommendation, but risk of having DVT is pretty high in first one month. Now, if patient have a confirmed DVT, let's say if patient have cerebral venous thrombosis or DVT of upper arm or lower arm or pulmonary embolism, these patients need warfarin for 3 months at least, or maybe up to 6 months. Okay. Now with this, we are done with HIT. In next couple of minutes, we will talk about how to diagnose ITP and management of ITP. Then we will talk about management of hemophilia and bleeding disorder. So I'm going to stop it here. Thank you.